Hello and welcome to this medication safety self-study course. I'm Jared Karen, your nurse educator, and I'll be presenting for you today. Our objectives for this session include defining what exactly we mean when we talk about medication safety, looking at some specific strategies to promote medication safety with things that we commonly do in the clinic, refills, med rec, and medication administration. Also, we'll look at what to do if you make a medication error. So to begin, let's talk about what medication safety is. What do we mean when we say that? Well, a good way to think about this is just the three words, do no harm. That's our goal. And so medication safety means being intentional and taking specific actions to prevent accidental harm to patients. This quote is very useful in this. Paracelcus was the guy who founded the science of toxicology, or studying poisons, and he reminds us that anything can be a poison. That includes the things that we give people to help them, like medications. So we want to be careful and pay attention to specific things when we're dealing with medications. So much of medication safety comes back to very fundamental things like the 8 rights. If you remember being taught 5 rights, that's okay, because the number has actually changed and we've added additional components because medications have become more complicated than they used to be. So the rights are the right patient, the right drug, the right dose, the right route, the right time, the right reason or why the medication is being given or prescribed, the right response, what happens after we give the medication, and then the right documentation, making sure that the appropriate details are recorded in the patient's medical record. So how do we look at these things and promote them with some of the common activities that we do in the practice? Let's talk about home medications first. Most of our patients are managing most of their medications at home without our direct input. So we have specific times when we can influence that. First being refills. This is something we do all the time. How do we pay attention to medication safety with this? Well, here's an example of a refill. And let's run through the 8 rights in this refill. Well, the first is the right patient. When might this be something we pay attention to? Well, basically, anytime that you're talking to anybody else in the patient's care, you'd want to be confirming the name and date of birth. Make sure you're talking about the same person. That would be like when you call the pharmacy, when you call the patient. Make sure you're in the right chart. When you're talking to the provider about something, that's a useful time to confirm that you have the right patient. Also, we have the right drug, dose, and route. So this is important because, as we know, the medication list in the medical record doesn't always reflect what is supposed to be happening. So we want to be careful and look not only at the med list, but also at some of the other information in the chart, recent office visits, phone notes, refills. Find out what the plan of care is and if this prescription matches that plan of care. Also, the right time. This involves 2 elements. First of all, the timing instructions for the patient. And then secondly, is it actually time for a refill? And so you want to pay attention to both of these things. One, that the instructions are actually specific enough for the patient to follow and that they match the drug, because sometimes that could be an issue. But in order to do that, you also need to know the right reason. Why is the medication being dispensed? Now, this refill is for 10 milligrams of methotrexate once a day. Now, that dose could be appropriate if the patient was being treated for cancer. But it also, if this is prescribed for an autoimmune condition, that dose is too high. And actually, this is based on a real case where a patient was dispensed a daily dose of methotrexate, 10 milligrams a day, that was intended to be once a week. And they took it because that's what it said on the bottle, and they died. That's a very severe example of what can happen with a refill. But either way, it's something we want to pay attention to. So knowing the right reason is important. The right response has to do with whether or not we've followed up on the appropriate things. This is where you might look at lab results. You might be looking at whether the patient has had appropriate follow-up visits. And then the right documentation. These are things like, is the prescription valid? Do we have appropriate follow-up in the chart? Is there, you might look at things like pain contracts. Those are forms of documentation you'd be looking for with a refill. So how do you know which labs and things to check? Well, you have some great resources available to you, one of which is Micromedics. And Micromedics has a section in it for each drug called monitoring, which is going to tell you specific things that the patient needs to have checked at specific intervals. So this is the section for methotrexate. There's a lot in it because methotrexate's a powerful drug, and it also is used for a lot of different things. So it will tell you whether the patient needs to be followed up in the office on a regular basis. It'll tell you what labs should be checked and when. And it's a great place to look if you're like, I don't know, is there labs we need to be looking for this? Great place to check. Micromedics monitoring section. Another big way that we impact patients' self-management medications is medication reconciliation. And of course, we do this all the time. Every day we're doing it when we room patients in office visits. But we want to focus on how we accomplish that, because the approach that we take and how we go through that conversation has a big impact on whether it's effective or not. So we're going to play 3 audio examples. And I want you to listen for what goes well, what maybe doesn't go so well, and what you might do differently in each of these. Hi, Miss Many Meds. You're here to see Dr. Wicked Quick, right?
Yeah, I just got out of the hospital, and I haven't been feeling
well, hey, I want to give you the most time with him as possible, so let's get started. Are there any changes to your medications?
Well, they didn't change anything, but the doctor told me...
Oh, great. That makes my job so easy. Let's get your blood pressure.
Well, I was trying to tell you. They told me
sorry, I have my stethoscope in. I can't really hear you.
Oh, goodness.
Hi, Miss Many Meds. You're here to see Dr. Wicked Quick, right?
Yeah, I just got out of the hospital. They started me on this new medication.
Oh, okay. Well, I'm glad you told me about that. Now I can add it to your list. Do you remember what it was called?
No, not exactly. I just know it's for my heartburn. It has this really long name. Here it is in the discharge paper.
Okay. Oh, all right. Yeah, omeprazole. I know that one. Let me add it to your med list here.
And I also started taking a baby aspirin. The doctor at the hospital told me to take it.
Okay, wait a minute. Slow down. I'm not quite done with this first one. Let me just get it in here. One more click. Okay. All right. And you said something about a baby aspirin. What's that?
Yeah, I have to take that every day. They also gave me this list out front to look at all these other medications. I was really confused at what they wanted me to do. So here's the list right here.
Okay, let me just add that aspirin in and then this list here. So did you see anything else that needed to change on this?
No, I don't think so, but they changed a lot at the hospital, so here you go.
Oh, so you don't really know what's going on with this?
Not particularly.
Yeah, let me let the doctor just figure that out, okay?
Okay.
I'm going to finish this part up and then we'll get your vital signs.
Okay.
Hi, Miss Many Meds. You're here to see Dr. Not So Fast, right?
Yeah, I just got out of the hospital, so I definitely need to see her.
Oh, I'm sorry to hear you were in the hospital, but I'm glad we're seeing you now so we can keep you out of there. Well, why don't we start by taking a look at the list of medications they handed you out front. Do you know if they added or changed any medications while you were in the hospital?
Actually, they did start me on a funny-sounding pill for indigestion. And they also told me to start a baby aspirin. I don't think they changed anything else, though I'm not exactly sure what all these medications are on this paper.
Okay, yeah, well, why don't we do this? Let's take a look at each one, starting at the top. So, are you still taking this 20 milligram tablet of lisinopril once a day? That one is for your blood pressure.
Oh yeah, I know that one, and I take it every day.
Okay, great. So how about this next one, the hydrocortisone cream? It's for your skin. It says here you use it 3 times a day.
Skin cream? I haven't used skin cream since, oh, you know what? That might be from the funny rash I had a few months ago. But no, I haven't needed that in a while.
Okay, well, that sounds like it might be an old prescription then. I'll make sure I update the list. Well, next here it says that you take the Lipitor 40 milligrams once a day at bedtime. Is that correct? That one is used for your cholesterol.
Yeah, that sounds right. I do take a pill at bedtime. But it's not called Lipitor. It's something statin. I think it starts with an A.
Okay, yeah, that's probably the generic version, which is called atorvastatin.
Yeah, that one. That's it. It's a really long name. You'd think they'd make them easier to say.
Yeah, I wish too. So after hearing all 3 of those, you probably noticed that the third one was, of the 3, the best one. while it wasn't perfect, a few things that you want to take away from this. Number one, don't assume the patient even knows that anything's changed. So a good way to apply this is to avoid using a simple yes or no question like, have any of your medications changed? The patient may not know. So a better approach is to assume that you're going to go through the whole list and start from the top. One of the things that the third example did better than the other two was a systematic approach. It started with the first medication on the list and just went through each one. That might sound like a little bit tedious work, but you'll notice that with patients who don't have a lot of changes, it goes quickly. For those who have a lot of changes, it allows you to get good information. Second, recognize that medication reconciliation is about having a good quality conversation with the patient. It's not about checking a box. It's not about clicking things in the computer. Make sure that you're able to have that conversation. So the third example, you notice that there was no tapping of keys or clicking a mouse. And we're not saying that you shouldn't be entering data at the same time. But if you find that it's a barrier to communicating with the patient, then feel free to do your data entry later. Use things like your paper med list as a way to frame that conversation and take control in a way that systematically goes through that med list and helps the patient. And focus on the idea that we want to have a good, accurate understanding of what the patient's taking at home. So let's switch gears here and talk about administering medications in the practice. Here's a scenario. Let's say you're rooming for Dr. Anonymous, who's seeing Mr. Smith, who's 50 years old, and he's being seen for a headache. So Dr. A comes out of a room, walks over to the nurse's station, and he's like, hey, let's give him some Toradol, and then he walks away. So what are you going to do in this situation? And how do we promote safety in a scenario like this? Well, first of all, we want to recognize that this is a verbal order. And we want to think about a couple of things we want to do for safety. First of all, we need to make sure that the order is complete. We need to make sure that we know who is getting the drug. What are we giving? What is the dose that is ordered and the route? If all four of those things are not present, you don't have a complete order, so you need more information. So in this case, we have to go and find Dr. A. We have to make sure that we get that information from him. And then what are we going to do once we get that? Well, we need to write it down. We need to write down all of that information, who ordered it, and also make sure you write down the time. That's going to come in handy when you document the verbal order. And then before you walk away from that physician or nurse practitioner who's given the order, read it back out loud to confirm that you heard it right. Because that's the big danger with verbal orders, is that you can think you heard one thing, but if you got it wrong, there's no way to make sure that that's the case. So make sure that this is a habit. Make sure you got all your information, write it down, read it back. And then when you're done giving the medication, you go to document it, you can use the quick text .verb to document a verbal order. And if you have all the information, you've done this on this slide, then you'll have everything you need to put into that documentation. Now, you might also need to do some dose calculation. Let's say that Dr. A clarifies and says that we're going to give 30 milligrams of ketorolac IM. So you get to the med room and you see the vial is 60 milligrams per 2 mils. So now you got to figure out how many milliliters you draw up. So this is math, and it's really not too complicated, but it's important to understand what you need in terms of which numbers and where to put them. So you need 3 numbers to do this equation. First one is what's ordered. So in this case, it's 30 milligrams. Pretty easy to find. Then we have to do what do we have on hand. So in that case, we have 60 milligrams. You always want to match the units in your fraction. So ordered over have should be the same units. So 30 milligrams over 60 milligrams. The third number that you need is the volume. In this case, 2 milliliters. If this was say it was tablets, that could be tablets. So it could be 200 milligrams in one tablet. That's a volume. It doesn't matter. Just get in the habit of finding those 3 numbers. And it's a good idea, even when it's an easy equation like this, to write out the math so that you get in the habit when you have an equation that's really not so easy. So now we just do the math. 30 divided by 60 times 2, and that gives us 1 milliliter. So we'll draw up 1 milliliter to inject in this patient. If you find that this is a little confusing and you need some practice on math, there is a medication math practice sheet available on the Pulse that you can download and practice some math equations. And we'd be happy in nursing to take a look at that and give you some feedback if you want. Another secret weapon in promoting medication safety in the practice is an independent double check. So what is this? Well, this is when two people independently confirm the 8 rights before you give a medication. And so a good way to do this is to actually have your colleague read out loud and verify the 8 rights off the order and the medication label, because that way, one, you're forcing them to actually slow down and look at what's there, and you can hear what they're saying and verify that that's the same thing you saw. So when do you do this? Do you do it every time? Well, some general guidelines: if you're a medical assistant, it's a good idea to do this whenever you're doing a drug calculation. And then if you're a nurse, you definitely want to do it if it's a new situation, you're unfamiliar with it, a new drug that you haven't given before, or it's kind of a complicated situation, maybe complicated calculations, or you're dealing with a high alert drug like warfarin or insulin. Those are good reasons to have an independent double check. Basically, if it makes sense or you feel like you want to have an independent double check, definitely do it. And then document it. Have both people's signatures in that chart. So what happens if you make an error? Nobody wants to talk about this, but it's really important that we get this right, because errors aren't the problem half the time. It's really about how you handle them. So what do we do if we do make an error? Well, the first thing you want to make sure you do is notify the responsible provider and make sure that we've assessed the patient for any potential harm. Then we need to create a follow-up plan. What are we going to do about that? Is there corrective treatment that needs to happen? If it's a vaccine error, do we need to revaccinate the patient? We need to figure out what the plan is. And then the patient also needs to be notified of the error and the plan. So this is pretty easy to do if the patient's still in the clinic. It's a little bit more difficult if they've already gone home, but all 4 of those things definitely need to happen. After you've done that, take care of the patient first, then submit an occurrence report. And just put the facts. Occurrence reports are not the same as writing somebody up. It's not getting people in trouble. It's just so that we can track the quality assurance side of it and make sure that we're addressing all the factors and supporting you in being safe with patients. So we can't fix problems that we don't know about. So when you submit an occurrence report, there's some follow-up that happens afterwards. And again, it's not punitive. You're not being written up. It's just to find out what happened and how can we prevent it in the future. And that might be changing policies and procedures. It might be getting better equipment. It might be providing education to support you and making sure that you have everything you need to practice safely. So when that comes around, it's usually a couple months later. It's not right away. So don't be concerned if you see us come for a case review and look at what happened. We're just trying to get information and support you. So you're not in trouble. Just remember that. So what are you going to document, though, if there's an error? Well, the first 4 items that are turning blue here, those are the things you want to put in the chart. Nothing about the occurrence report or the quality assurance process goes into the medical record, okay? You never document that you filed an occurrence report. You never document that you contacted quality. Those are separate things. One has to do with the patient's care. That's what goes in the medical record. The rest is internal quality assurance. It's a completely different side of things, so it doesn't belong in their medical record. But of course, we'd all like to avoid making errors in the first place. So something to think about, as a human being, there's going to be times when we're more likely to make errors. So you want to be aware of certain things, like, are you in a new or unfamiliar situation? Are you being rushed? Are you trying to multitask or getting distracted or interrupted? Other things like, are you under emotional stress? That can make you more likely to make an error. Are you tired? Is it the end of the day, right before lunch? Those are times when people tend to make more errors. Or is it just a situation where you just don't know enough? You don't have the knowledge. Be aware of that so that you can get somebody who does know and can help you. So basically, it's an idea of just keeping aware of your mental state so that you can take a time out so you can promote safety. So let's wrap this up. What can you do today to promote safety? Well, first, get in the habit of checking the 8 rights as a second nature, even when you're dealing with things like refills, that when the patient's not in front of you, we still want to make sure we're dotting those I's and crossing those T's. We also want to handle verbal orders safely by reading back and confirming and documenting them in the chart. Also, use your evidence-based resources because your knowledge base will help you in this. So don't be afraid to look things up. Know that you can use UpToDate or Micromedics to look up medication information, and they're pretty easy to use. If you need help, feel free to contact us and we'll walk you through it. Also, cultivate self-awareness of how you're feeling. What's your mental state? And be prepared to take a time out if you're feeling like you're stressed out, rushed, or distracted. All right. There's no exam, but you will have a short quiz after this, just to give yourself an idea of your knowledge. Thank you for listening.